So if you can take part in this, what you'll first be presented with is a vignette of a very common clinical presentation. What we're trying to do here is to give people examples of the most normal things that come through clinical practice every day, and to try and give people who maybe aren't as familiar with, in this case, managing shoulder problems, just some guidance on what they should do. So for example, here's the clinical vignette that you would see, and then what we're going to ask you is, if this was your patient and you've just got a normal amount of time for this assessment on that first time when they come through the door, what other questions would you like to prioritize to do in their assessment? So we're not going to be doing the world's most comprehensive examination that's ever been done for these patients, but given your normal time constraints, what other things do you need to find out? So a list of these will be presented in this first round, and you can add to those if you want. But then once I've collated everybody's responses, pulled all of the separate ones together wherever that's able, made any changes to the vignette, you would then be asked to vote for each of those. So for example, red flags: are these a must, should, could, should not, must not, any associated neck symptoms, and so on and so on. Once we get all of the votes for that, the votes will just be gathered. So for example, when we did this in the first instance, we had 9 out of the 10 people, or 9 out of 11 it looks like, saying that you must ask about red flags, and one person said you should. And occasionally there's complete agreement here on asking about pain behavior, but there's a little bit of disagreement, although everybody is saying that this is something that is in must, should, or could in regards social history. With all of that information, you'll then be presented in the next round with some information about the physical examination. So we'll have identified some PSFS items, and then on exam we'll give you a handful of different things, and then we just want to add anything else for the physical examination that you'd recommend. Now again, we want to think about those normal time constraints of your patient coming through for that first examination. We'll go through the same process and then again vote given what you've found so far, and we'll probably have a few findings of the key things that we think would have been found in that initial clinical examination. Once that same process goes through, and we'll then vote for that as to what you think must, could, should not, must not. A couple of brave souls are then going to take on the task of deciding how will we answer that patient's questions on day one. So given all the information we have, what's your best guess as to what's wrong with the patient? What's your best guess in regards to the prognosis? And what do we think would be our most likely options for management for this particular condition? Hopefully what we'll get done out of these is perhaps the 5 or 7 conditions that are most likely going to come through in a normal shoulder practice, and to be able to give people some guidance for that. And then we're going to rinse and repeat this for knees, ankles, hips, necks, low backs, elbows, and perhaps even hands. And then these can be revisited once we get through all of that cycle. I think that's going to take a couple of years, but you as the shoulder experts would only be involved in these shoulder ones unless you want to jump into some of the others. So I hope you can join us, and we'll start this process in the next couple of weeks or so.